10-4.
10-4. Is that Dave 1 or Dave 2?
He's running some tests in the background, so it's just Dave 1.
Just Dave 1.
Yeah,
All
The
right.
OG.
The OG.
the OG.
Is everybody ready? We're at 11:55. We
Turning
got
camera
about
off.
25 people in the waiting room, so we'll have a good scrum here at the beginning. Michelle will be inviting people to identify where they're zooming from and what their program is. And Alicia, you'll kick us off. I'll put up the word cloud, and then we'll comment on the word cloud.
Sounds good.
All right, go ahead, Lee.
Done.
Thank you, sir.
Welcome, everyone. Our event formally begins at 12:05. While people are joining us, we invite you to participate in the following poll: what does human trafficking mean to you? And Chris Hall, CAIEP Director, will share the ways you can participate in the poll.
Thanks, everyone. Good to see you here. So if you have Poll Everywhere on your phone already, you can open the app.
This is our 250th anniversary.
And if you're not muted, you might want to do that. Or you can open up a new browser to pollev.com/UNE CAIEP, or you can text it to 2233. And I believe the link for the poll is also in the chat. But the question is, as Alicia mentioned, is what does human trafficking mean to you? You can also scan the QR code. Can you see that screen, everyone? The word cloud screen? All right. I see that we're waiting on responses. And we're hoping to just get a sense of where you are in your thinking about it.
Someone said that the QR code disappeared.
The QR code
Or
may
is
have
it just
disappeared,
small?
but it is in the upper right-hand corner. Alternatively, I think the link is in the chat as well. But I don't have any trouble taking us back. Oh, there we go.
And panelists, please join me in discussing the word cloud as responses start coming in here.
I'm like trying to navigate reading folks who are coming in. I was getting distracted by who was coming in the room. Thank you for the reminder. Traumatizing, invisible fear, unknown, controlled.
I saw survivor.
Without content. I'm curious about the word control and controlled. Okay, I think I see. Yep.
The fact that the word invisible is so large, I think, is indicative of why we're here today.
Yeah, some of these words are much bigger. We're seeing fear, trauma, invisible.
I think dehumanizing.
Absolutely.
That's one thing that I always felt like I was experiencing a lot, is like feeling like I was less than human.
You're really
The silence really hits for me. How much isn't talked about, how much is seen but isn't talked about, how much is done but isn't talked about.
I don't see stigma here. I sort of expected that would pop up.
It is also interesting the words that aren't here and what we'll be talking about with the definition. Right. Work and labor are words that are not on the word cloud right now, right?
Yeah.
Actually, I see the word alone too. And I think that, I know for me at least, that was a lot of like also experiencing this really intense isolation.
As I'm reading, I'm wondering how many of these words are about trafficking survivors or about people themselves. Some of the things they may be feeling coming into this.
And I'll say a welcome once again to everyone who has been joining us. We'll begin at 12:05. But please participate in the poll, and Chris Hall, our CAIEP director, will share ways that you can do that.
Thank you, Alicia. The ways to participate in the poll include, if you have Poll Everywhere as the app on your phone, that's probably the most straightforward way. You can scan the QR code in the upper right-hand corner, or you can open a new browser and join that way. Thank you for participating. I see fear there, and it makes me think there's fear on all sides because there may be fear in disclosing or fear in taking action, but also as a clinician, it's possible to be anxious and fearful of how are you going to take care of this person who may be experiencing tremendous need and difficulty.
Mhm. See the word advantage. I'm curious. Curious.
This is a very heavy word cloud. And I think today's content will talk a little bit about how to lift that heaviness.
Mm.
And we're seeing parts of the definition coming through that I know Hailey will talk about: forced and control, manipulation.
The word used, I just saw. Curious.
I think the word disregarding is interesting too, because so often we see that people's experiences, I think sometimes within the legal system, it can feel like that they're being disregarded.
I was thinking of that with the word cycle as well, that there are so many cyclical elements of trafficking and the reasons and the conditions that continue to perpetuate trafficking, right? The cyclical nature of it itself and the systems and structures that create these cycles.
Absolutely. And I did see resilience show up there, and I love that that made it into the word cloud, thinking about the idea of being resilient and moving on, and not just the idea of victimization.
That's right.
Mm-hmm. Mm. It's so quick. It moves so much.
I'm interested in that systems and cycles. Can you talk a little bit more about that? What does that mean to you?
Yeah, for me, when I think about who we've worked with in the past and the ways in which structural oppression or systemic violence have impacted people, those are the conditions that create actions of trafficking, right? When people are without the ability to meet their basic needs because the access isn't there, not because that's inherent to the person. Or, more specifically, we work with so many individuals who are criminalized. And so the cycle then becomes incarceration to being robbed of opportunities to further oppression, to further incarceration, and so forth. And so, that resiliency, can't find the word now, but that resiliency is so important. And oftentimes it's an unnecessary level of resiliency that people must possess to move through this.
Thank you. That's very helpful.
And I think of it too in terms of like the systems that I was involved in. I know for me, like, and I will talk about this more, but when I did seek help for my mental health and my substance use, kind of inadvertently, that ended up being discredited a lot of in the legal system in terms of being able to find a path forward for me with my trafficker in the family court system. And so that was kind of another way in which this individual was able to still have some control over myself and my family. So.
Yeah. And I think in talking with survivors, I think one of the things that stands out is how many barriers there are in terms of trying to access systems that are intended to meet needs that people have, but there are so many limitations.
All right. Thank you. Thanks everyone for participating in the poll. Alicia, are you ready to begin?
Ready.
Ready? Dave and Lee, ready to begin?
Ready.
Okay, thank you. Go ahead.
All right, welcome everyone to the Center to Advance Interprofessional Education and Practice Knowledge Exchange, titled Healthcare Pathways to Safety and Support, Improving Clinical Response to Human Trafficking, designed in collaboration with UNE School of Criminology, Society and Politics, as well as Preble Street's Anti-Trafficking Services Program. We would like to welcome UNE students. It is great to see so many professions identified in the chat. Welcome community members, prospective students, alumni, and students from other universities that are here with us today. We're so glad that you're joining us. My name is Alicia Peters, and I am Associate Professor of Anthropology in the School of Criminology, Society and Politics here at the University of New England. And I will be your host today for our exploration of the roles that healthcare providers play in taking a survivor-centered team approach in the clinic to identify and provide trauma-informed care for individuals who have experienced human trafficking. I hope you will participate today from a place of curiosity and compassion as we learn together about interprofessional approaches to care. Near the end of the event, we will share a survey link that will capture student attendance and community participation. Please let us know how we did by completing the survey. And these are our learning objectives, which we will also place in the chat. Be listening for ways that you can plan to incorporate some of what you will learn today into your future practice. And this topic can activate difficult feelings. I'd like to remind our students, especially of the many campus resources that are available to you if you need support during or following the presentation. And we are very lucky to have 4 incredible panelists joining us today. I will introduce them briefly and then ask them each to say a little more about themselves as they join the conversation. So first, we have Hailey Virusso, who is Director of Anti-Trafficking Services at Preble Street. We have Alane O'Connor, who is Director of Perinatal Addiction Medicine at MaineHealth and Maine Medical Center. Ray Gaddis is a founding member of Preble Street Survivor Advisory Board, and Amanda Place is Director of Residential Services at Recovery Connections of Maine and also a founding member of Preble Street Survivor Advisory Board. And to get us started, Ray is going to lead us in a breathing exercise.
Salve, y'all. I'm going to set my timer. I'm going to ask that we all just start by putting our feet down flat on the ground. As we're doing that, we're taking some delicious breath. Eyes open, eyes closed. Doesn't matter. Keep relaxing where your feet are, your toes. Relax your knees. Keep breathing in through your nose, out through your mouth if that feels comfortable. The goal is to feel the whole body, y'all. You have a brain, you have a heart, you have organs, you have muscles. Let your whole body be filled. Let that breath come in fully, all the way, and out fully. You are a natural cleanser. You are nature. So let that breath come in and get cleansed and take what it needs. Deep and release. Each time, let all of that breath go, every little bit of it. It's been cleaned and it goes out to nature, and nature gets to use what you've just given it. Keep breathing in, keep relaxing, let go of the gut, let go of the shoulders, let go of the jaw. And we're moving forward. Thank you so much. Keep breathing. Don't let go. Don't let go.
All right, thank you, Ray. Before we dive into the main content of the discussion, I'd like to ask Hailey to help the audience understand what it is we mean when we say human trafficking. There's a lot of confusion around that term, so it's useful to be clear about what it is we are focusing on today.
Thank you so much, Alicia. So human trafficking is any compelled activity, whether for labor, services, and/or commercial sex, where the use of force, fraud, or coercive methods are used for someone else's economic gain, or any minor, so someone under the age of 18 is involved in commercial sex. So human trafficking is really this umbrella term that is defining both labor trafficking and sex trafficking. And we choose to look at human trafficking through a public health lens, meaning we want to understand the conditions that perpetuate trafficking and how they impact communities and the individual. And so one of the ways in which the United States sought to address trafficking was only 26 years ago with the establishment of the Trafficking Victims Protection Act. And it took what's called a three-pronged approach at addressing trafficking. It addressed criminal prosecutions and penalties of traffickers. It created immigration protections for foreign-born victims. It focused on prevention efforts and partnership building activities. That also included civil remedies and victims' benefits. But one of the most important parts about the TVPA is that it legally defined severe forms of trafficking. Because if we don't have shared language and a shared understanding of what this issue is, what human trafficking is, and what those root causes are, which, as I said before, have to do with the systems and structures that exist in our community, to really effectively engage in a coordinated community response, right, of disciplines across the board, like you all, we need to understand what we're talking about. And so as we sought to legally define this, we are able to engage in effective strategy making to address human trafficking. Again, so much of our media's attention has focused on sex trafficking. I do encourage you to have this perspective rounded out, that when you zoom out to global statistics, and these are replicated here in Maine, that labor trafficking and severe forms of labor exploitation are some of the most prominent experiences of trafficking across the globe. It accounts for about 80% of all cases of that, and those have an intersection with forced labor. Next slide. And so to understand this, the AMP model helps give life to this term, because at the end of the day, human trafficking is also a legal term. And so this looks at action, means, and purpose. The actions are the methods that somebody is recruited into a trafficking victimization. The means are the ways in which somebody's maintained in that victimization, force, fraud, or coercion. And the purpose is for the reason why. And so recruitment into a trafficking victimization can be as simple as applying for a job, and that the coercive methods could be used through psychological manipulation for folks with an immigration relief need, withholding their paperwork, their documentation, to force them into some form of labor or services. This means column, force, fraud, or coercion. Only one of those elements needs to be present in order for it to rise to the level of trafficking, right? Force, fraud, or coercion. But in order for something to be delineated between an exploitative circumstance and a trafficking victimization, something from each column, so action, means, and purpose, does need to be present. The one caveat to that definition is for minors who have experienced sex trafficking, that this means column is not necessary, meaning a minor who's trading sex for a place to stay, trading sex for food or substances under the federal act is considered a victim of trafficking. That certainly does not mean they identify that way. And our jobs are never to elicit disclosures from the people that we work with. Our job is to understand this definition and start to normalize pathways to having difficult conversations with folks, normalize pathways to having the language to support folks in attaining that language themselves, and finding ways to support survivors in meeting their needs. Because ultimately, these trafficking victimizations meet needs, whether they're intangible needs, connection, tangible needs, financial, housing, substances. Victimizations meet needs. And our goal as providers, as community members, is to support individuals through building relationship and finding safe strategies in order to meet these needs outside of that victimization. Thank you, Chris.
All right, thank you so much for adding that clarity to the definition, Hailey. And now I will ask each of our panelists to briefly respond to the question, what do you want future healthcare providers to know if they encounter a potential trafficking survivor in their work? And let's start with Amanda.
Yeah, I think, oh, sorry, there I am. I think for me, what I would want people to know is just how important the relationship, like the relationships that people have with providers, and being able to maintain those connections. I know that sometimes it can be hard But, you know, people just continuing to be there and be supportive. I know for me, it was like, regardless of what my decisions were, or there was a period of time where I was continuing to go back to my trafficker. And I know that some of the healthcare providers that I was working with at the time did a really good job of continuing to support me despite me continuing to go back to that situation, which I'll talk more about later. But that kind of meeting people with unconditional positive regard is, in my opinion, very, very important.
Thank you so much for sharing that, Amanda. And we will go next to Ray.
I got a little emotional. The thing that is most important is what Amanda's talking about. It's that relationship. I had one healthcare provider in 9th grade who finally listened to me for the first time when I said I was in pain. And she was the first person who did anything to get not just the meds that I needed, but then she stayed in relationship with me all through high school. And then after high school, she would find my number because it just so happened her daughter was in my class. She would find my number and she would figure out how to check in on me at least once or twice a year. I'm not saying you have to bridge that gap of being like that with all of your clients, but as a scared 15-year-old who sees her on the street and she still hugs me, asks me how I'm doing, she's doing protests a block away from where I live. I know her, she knows me. It's been 20-something years of a beautiful relationship with this human who trusted me to listen and trusted her instincts to do the right thing. Thank you for listening.
Thank you, Ray. And I so appreciate both Amanda and Ray sharing their lived experience and bringing that into the conversation. And we'll go next to Alane.
Hi, everybody. Great to see you all today. I come really from the perspective as a medical provider who's working with high or folks who are at risk for this situation. And I want to speak to you from the lens of like, it's okay if you don't know everything, right? When you're working with a patient who's struggling with all kinds of different things, like understand that trust takes time. And the most important thing you can do when you're working with a patient is just kind of walk in the room, sit down, be at eye level, put all the stuff away, and just listen. And I think, not expecting people to tell you everything, on the first visit, but rather just building that trust. And recognizing that this really, like fear really spoke to me on the word cloud in the beginning, because I would say that's the most common sort of presentation I see where people are just sort of wondering, is this a safe place to disclose something? Is this a safe person to talk to? Am I safe in this setting? Oftentimes you'll see people who are, their phone is just pinging constantly, or they're like, I gotta go, this person's waiting for me outside. So there's just a lot of things going on. And I think just sitting in a space where you're a source of support and comfort and working with people in whatever they want to share in that moment. And recognizing that you just need to have some resources available for folks when you're working with people so that you do have the ability kind of real time to intervene depending on what they are willing to share with you. So we'll talk more about that in a little bit too.
Thank you so much, Alane. And we will go to Hailey.
Great. Relationship is key, and I think that's clearly being driven home by all of my colleagues. Ultimately, when we are working with people, we want to lead with what people want, what their vision for their life is. Why are they coming to you? And so, I think of conversations I've had with providers about just the power of staying in your lane, doing what you do and doing that thing exceptionally well. Because ultimately, as I shared before, addressing human trafficking does not fall with one person, one provider, one community. It really does require a group of individuals who are committed to ending the conditions that perpetuate exploitation. So in an individual conversation, right, this can happen at the micro, meso, and macro levels, right? At the individual level, it's exactly what Alane just talked about, what Ray and Amanda just talked about. It's meeting people where they're at and following their decisions, and actually trusting that the people that we work with are so much smarter than we are about their own circumstances, right? We are not, it's so trite, but social workers talk about that people are the experts of their own lives. But that's simply true, right? Our advice is never as good as we think it is. And if our initial suggestion to a survivor of trafficking is around exiting, then we haven't listened deeply enough. Because as I said before, these situations are so much more complex and intertwined into both the relational dynamic, but all the structures that an individual has to navigate through. And so if we listen deeply and we meet somebody, as Amanda said, with unconditional positive regard, again, just holding that they know what they want for themselves and they know how to get there, our role can really be a bridge. You may be the expert in the resources available or the medical care available, then do that really well, because then you're helping somebody to meet the need that they came to see you for. Then at the meso level, how do we ensure that our work is centering the people it's designed to center? So whether that means use client-centered language, patient-centered language, survivor-centered language. I feel deeply privileged to be on this panel with Ray and Amanda today, who founded our Survivor Advisory Board, who lets us know when our work is straying from the goal and purpose of it, which is to listen to the people we're designed to serve. And part of that is also our own reflection. Our biases of who can be a victim of trafficking and who cannot be will directly reinforce who gains access to services and who doesn't. And so when you think about who your mind's eye conjures up as a victim of trafficking, right? That's your bias. That person that comes to mind is your bias. And we all have that, but it's so important to ensure that you all know, right? There's no one face of a trafficking victim. There's no one face of somebody who perpetuates harm. And that oftentimes the people that we work with have been criminalized inappropriately so for the victimizations they've endured. And so again, as we listen deeply, as we connect with people and we hear their stories, we're then more effectively able to support them in figuring out, is exit what I want? Or do I just want to make my situation a little bit safer? And then how can you as a provider do that? And again, that's by listening, right? And so it can feel so overwhelming to think that the person in front of you is a victim of human trafficking. And that word, again, conjures up so many, fear, control are the biggest ones that I remember seeing on the word cloud. I also believe that that's likely the internal experience that many providers have of fear, and I need to control this, and how do I fix this? Your job is simply not to fix this situation. Your job is simply to be someone in a dignified, committed relationship with the person in front of you, and they will do the rest, right? And so again, so that also sometimes means just trusting your gut, trusting that if something feels a little off, that's okay. And you might not need to know the intimate details of why that situation's not okay. As I said before, eliciting disclosure is never our goal. Our goal is to meet the needs that somebody is coming to us with. And maybe they feel comfortable to share that information, or maybe sharing that information ends up being really harmful. But ultimately, our goal is to listen, to connect folks with resources that make sense for them, to believe them when they share this experience has happened, to understand some of the misconceptions of trafficking, right? Victims of trafficking can receive money for their services, right? That's part of it. Victims of trafficking do not need to be moved from one location to the next. It can happen in one location. Going across a state, city, or country line does not mean that it's an instance of trafficking. And so understanding some of those misconceptions will better allow you to understand the person in front of you, the needs they're coming with, and how to support them.
Thank you so much, Hailey. And I just want to pick up on some of the themes that we're hearing from all of our panelists. The need to listen, to support potential survivors, trust, to provide comfort, and meeting people where they're at and meeting their needs. So not necessarily fixing the problem or prioritizing exit, but really focusing on all of those other aspects. And so I want to offer the panelists an opportunity to respond to one another or pick up on anything that has been said so far.
When I think about the folks that I work with, so I work both as a perinatal addiction medicine specialist, but I also work in the correctional system. So when I think about the women that I work with that are really most at risk, oftentimes those are the incarcerated folks. So I forget, I think it was Hailey was making the point that, sometimes they've had to exchange money and, do things that have gotten them in trouble potentially with the law. It's not uncommon for folks who are in a very controlling relationship to actually take the charges for their partner. And so that's something that, you just have to listen and sort of understand. And again, not judge. Like, I think every time I'm working with a patient with a really complex social need, I just sit there in a space which is like, I don't understand everything that's going on by any stretch, right? Like, I have little pieces of information and I'm going to try to support them in that way. So, and substance use disorder, sorry, I don't know where that's coming from, but the substance use disorder is also something that's puts people at risk. So for those of you that don't work with folks with substance use disorder, when they are in the throes of their addiction and they're not in treatment or they're needing their next substance to sort of cure that withdrawal syndrome, that's a desperate situation for people. And oftentimes you'll have people kind of kept in the throes of the addiction, and people will almost be controlling their access to treatment, to other things, and that can be like a sense of desperation for the women that I work with. I just want to acknowledge too that like the reproductive situation is often under control. I have patients who are like forced into pregnancy as a means of sort of showing control. And when I think about the sort of highest risk situations I see in my own clinical practice, it's folks with a lot of fear who are working with me, who oftentimes have older partners, very controlling partners, the partners that don't want to go outside the room, and the partner that's continuing to call them like almost incessantly, like that phone that's kind of sitting behind them that's just pinging constantly. And you see that sense of desperation because they're wondering what that person's saying. And being able to assist them with whatever they need in that moment. Maybe it's a bag of food, maybe it's something else, maybe it's a ride somewhere. It doesn't have to be sort of a profound thing in that moment, but the opportunity to sort of intervene to help them with what they need in that moment shows that you care about them. And I always say that the most important thing when you're working with a patient at the first visit is to make sure they want to come back and see you the second time. And so whatever gets you there is what gets you there. And so being able to make phone calls with a patient can be helpful. I have a team of folks who will have a lot of resources in place and will say, hey, would it be helpful for us to make a phone call with you today? Is that something that would be good for you or that you would like to do? Putting the control back into their hands about how do you want this visit to go? What are your goals at this visit? And how do we support you in the best way that we can? And recognizing that sort of the relationship building and the trust in you, it takes time. People don't walk in when they've had situations that these folks have been through, just automatically trust you, even if you are a medical provider or social worker. It takes time to build that trust, to know that it's a safe place. And just constantly reassuring that point, I think is so helpful when working with folks. And it's intimidating, and we can just acknowledge that, right? But just doing the best you can. You have the basic skills there, the communication, the desire to help. You're all enrolled in some sort of health field. And so just meeting people where they're at, looking them in the eye, having a conversation, I think is just really helpful and shows that you care about them and that you want to support them in whatever they're willing to share with you that day.
Thank you, Alane. And I think that's such an important point also about treating people's the social conditions that they may be dealing with and meeting those needs. So whether they're medical or not, that they're, those needs, addressing those needs will help to build trust. Would any of our other panelists like to
I was
jump in?
going to say, kind of speaking off to a little bit of what Alane and Hailey were talking about too, is just like, the healthcare providers that I worked with that I found to be the most effective for me were people who like didn't have expectations regarding my what my experience was going to be, right? So a lot of times for me the trauma response would be triggered when I felt like somebody was trying to control me. So what I would experience in working with healthcare providers would be like, okay, well, you need to do these things. And if you don't do these things, then we can't help you. We can no longer help you. And so for me, it was really important to be able to have people that were willing to support me without, I call it like strings attached, not having that kind of pressure to please the provider that I'm working with, but more importantly to, recover and heal on my own terms.
I'm going to jump in there and just what you all just said. And Amanda, you triggered something for me. Because Peggy Akers was the only person listening to me as a young person about what was happening to me, I eventually stopped going to my OBGYN appointments. I eventually stopped going to my dentist appointments. I eventually stopped letting anyone touch my body, because no matter how many times I said something was wrong and I wasn't being listened to, people kept not only telling me I was wrong, but then telling me I was failing the tests that they were giving me. And so over and over, I was being told I'm failing tests and those signs aren't coming up, but my body is bleeding at a rate that is unreal. So I stopped for 18 years. And then 2.5 years ago, my body started doing weird things. I decided I got to go see a doctor. I got MaineCare real quick. I went to the UNE dentist school. I was in that chair for 19 procedures. I went to OBGYN for the first time, and I was diagnosed with a quadruple myomectomy, needing a quadruple myomectomy and a hysterectomy. And all of that happened in 3 months because they were growing so fast, people were scared. Doctors were scared. So again, that relationship is so important, because when you lose us, when you tell us no, we really internalize that because we come from a system that already told us no. It bred it really, really deep inside of us. So the minute you give us that no, you make a potential for a really long, long wait.
Okay, thank you, Amanda and Ray. That's really powerful hearing your experiences and what was harmful and what was most helpful. So Hailey, I want to invite you back to address this question of how can you support survivors?
And I think it's evident, right, from what everyone has shared. Connection, support, relationship, being authentic to you as a person as well. We work with folks who experience really high rates of hypervigilance, and so can certainly sense if the words that you're saying are not authentic to you as the provider. And whenever we can, ensuring that autonomy, decision making, that the survivor's voice, the patient's voice is centered in all decisions, and really respecting that. Because again, if there's one thing that we can kind of take away is your advice is not as good as you think it is. And that's a powerful, really freeing statement, because that means the person in front of you is there to guide you through that. Your job is to just show up accordingly. So thank you.
Thank you. And so we next will be moving into breakout rooms. So please turn your videos on and be ready to introduce yourselves and your profession or role in working with individuals who have experienced human trafficking. If your breakout room does not have a designated facilitator, please take the lead by introducing yourself and addressing one or more of the discussion prompts. If each group can please also assign a scribe and be ready to place the takeaways from your group discussion in the chat. Once we return, you might want to copy any notes that you put in your internal group chat, and then you can paste them into the larger group when we return. So we'll spend about 10 or 15 minutes in those breakout rooms, and we are providing a case example here. It will also be posted in the chat, and I'll read that just to give people an opportunity to process. So a 28-year-old female with a history of recent incarceration and ongoing opioid use disorder presents for care. She is very guarded and closed off during the first interview. Her significantly older partner is asked to wait outside the visit and is aggressive towards staff. The patient is eager to end the visit as she is afraid she is going to be, quote unquote, in trouble. Her phone rings frequently during the visit and she appears fearful. During an appointment with a physician, the patient agrees to start medication for opioid use disorder, but she does not want to discuss any other issues at the visit. The partner continues to attend appointments with her, and staff observes that he is controlling of her behavior in the waiting room. Many visits later, the patient discloses that her partner is forcing her to sell her medication, injects her with heroin and fentanyl, and trades her for sex with the individuals he acquires drugs from. And we will also share some discussion prompts to discuss in the breakout groups. So what elements suggest trafficking may be involved in this case? How might you respond? What kinds of questions should you ask or avoid asking? And what kinds of resources might you offer? And so I think we, at this time, are going to move into those breakout rooms.
for coming back. Everyone should be back by now. And Alicia, if you want to go ahead and get started.
All right, welcome back. At this time, I'd like to invite the scribes for each breakout group to go ahead and drop your takeaways into the chat. I also know that the presenters joined breakout rooms, so if I didn't invite each of them to share a little bit about your group's takeaways while we wait for everybody to add those notes to the chat.
Do you want us to jump in? Hailey and I
You-
co-facilitated a group. So
Oh, great.
some of the things that we talked about were really the challenges about being able to talk to people privately, like being able to sort of separate out particularly when you have a very controlling partner. I talked about some of the creative ways in which we've done that in my practice, which it seems to land better with the patient, the controlling partner, not to say we don't want you here, we want you over there, but rather to sort of encourage them to come help, or hey, we have this resource over here, can you come assist me with this, or something that makes them feel like they're participating in some way as opposed to being sort of blocked. But the challenge is that with that, one of the medical students said it would be really helpful to have sample patients that had, experiences with human trafficking. So being able to sort of ask the questions when you do sample patients. Folks reflected on how their own bias and experience impacts how we identify people and their vulnerabilities. So I thought that was a really rich conversation. Conversation about labor trafficking, the high prevalence of that, and that really sometimes the only care that they are able to access is healthcare. And then the importance of meeting vulnerable people where they're at, particularly in rural settings with rural workers. And then we had a little bit of a conversation about kind of what to ask or what not to ask, like kind of what are some of the most effective questions. So Hailey, was there anything else? I was madly writing.
I can't imagine what I would add to that. Thank you, Alane.
That's great. And I see that we have some takeaways coming in the chat. Would any of the groups like to share what you talked about?
I'm seeing a lot about the importance of self-reflection as a practitioner. I'm seeing that a lot. And being connected.
Yeah, I'm seeing things about trauma-centered care and the importance of confidentiality, which is really important.
I think one of the things that stood out in our conversation, there were two things. So all the things that we identified that might be red flags were aligned with power and control or our work with domestic violence survivors. And so that was, something that we were able to say, if we know how to work with domestic violence survivors, a lot of these skills are translatable to working with survivors of human trafficking. And then another thing, how might we respond? The ability to navigate the legal and ethical and systemic ramifications. So what we know is that when you're in MOUD treatment, you often get urine drug screens. And we're required, patients are required to sign full releases for therapy or alcohol and drug counseling to probation and parole, to child protective services, those types of things. And then we're expected, so it's almost like we get co-opted into being another arm of these systems. And how do we engage from a philosophy, not harm reduction by way of these tools of those two, fentanyl test strips, syringe exchange, these types of things, but also the harm reduction philosophy of how do I cause least harm in this situation? How do I consult and advocate to have the person be exempt potentially from a urine drug screen? Because if heroin and fentanyl show up on that, what does that mean for her ability to continue receiving MOUD treatment? And then what does that mean in terms of the ramifications from her partner if she loses access to that? So there's a lot of normative practices that we engage in that can actually cause a lot of harm, and at the same time decenter the client from what we're trying to offer in terms of support and help and trust and safety. So
Thank you. And I think that's a really important point about not replicating the kinds of control that may already be present in a trafficking situation when you're in a position to offer care and support. Would any other groups like to share out what you talked about?
I know that our group talked about, a lot of people talked about building rapport, like starting there. And I thought that was so insightful. Because I know for me, if I'm to start working with a provider, even now, even many years into recovery, I want to know if you have a dog, right? Like, I want to know that you're human too. And so, I think we're always walking that fine line of like, not overutilizing self-disclosure, but just people talking about just, showing up authentically as themselves and starting with the rapport building. So.
Thank you. And anybody else? And we can also open it up for a quick question or two for our panelists now that people have had time to discuss this more in their groups.
I did have a question.
Okay, go ahead.
Yeah, so it was brought up in our group the issue of just a hard situation perhaps where we want to help the individual, the victim, but perhaps with the abuser like out in the waiting room, if we don't want to like signal them that like something has changed, like our demeanor as practitioners has changed. And so like I think there was an emphasis on like trying to provide a safe space for the victim to be able to talk and just say what help that and or support that they need. But I was wondering if there was anything that the panelists could speak to about that issue of potentially not signaling to the person who is controlling that something is up.
I have an initial thought, Alicia, that first and foremost, if you have not engaged in the activity where you interview somebody and you record only yourself during that interview, I would highly recommend it. I know in the pandemic world, we all saw our faces far more readily as we do right now, right? Talking and engaging, but there's something really powerful about videotaping yourself where you can't actively see it, interviewing somebody about a topic you don't know what they're going to share about, so you get a better sense of what do my less obvious reactions look like, and so that I can have some awareness, because I feel like what you're saying first and foremost is how do I build some awareness about the way I present in these settings. And then I think the other piece of this is oftentimes you will likely be thinking far more about it than the person in the waiting room. The person in the waiting room likely is not making the assumption that this person is safety planning with you to exit the situation. So unless there's something really blaringly different about what you're presenting with, although that hypervigilance exists on kind of both sides of the house, there's sometimes this there's the system of entitlement. You all are talking about power and control, right? There's this presumption that, well, that's not going to happen. I have control. I have exacted that control. So, so I guess I would just offer that as well, but certainly would encourage folks to interview somebody on a topic you don't know what they're going to talk about, so that you really have an opportunity to see what your in the real moment reaction looks like. It's very telling.
Thank you so much. And we've come to the conclusion of our time, unfortunately. I think we could have gone on and on, but thank you everyone for attending. Please let us know how we did in the participation survey and attendance link that is in the chat. Please join us on Wednesday, April 1st from 12 to 1 for our next event, Launching into Adulthood, Navigating Pediatric Healthcare with Teens Who Have Disabilities, featuring experts who will share ways to empower teenagers with disabilities to take charge of their health as they mature, understanding the shift from pediatric to adult healthcare models while managing complex needs. And this event will be hosted by Maine Leadership Education in Neurodevelopmental and Related Disabilities, or the LEND program, and details will be in the chat. So we appreciate your attendance at all our events. Participation may be applied for UNE students to your IP honors distinction application, which demonstrates team readiness to your future employers. And all CAIEP events are available for inclusion in the curriculum. So thank you all and have a wonderful rest of your day.